Right, thank you, Professor Lin, for the kind introduction. I'm not sure who wrote all those biodata. I'm quite flattered about it. Okay, I've been given this task to talk to you about cancer in children and also adolescents in Malaysia, and what's the progress and what are the current challenges. So this is the latest incidence on childhood cancer as reported by the National Cancer Registry. It is for a period from 2007 to 2016. And over this period, for children below the age of 15 years old, it is reported that about less than 600 children were diagnosed with cancer over this period. We know this is underreported because this is census that we have collected amongst the pediatric oncologists treating children with cancer throughout the country. It's a very old data, but it is still relevant, and from this we gathered that about 700 odd patients are diagnosed with cancer, and these are mostly children below the age of 15. So there's about 100 odd patients who are not captured in the National Cancer Registry. As to the place where I work, Hospital Kuala Lumpur and now Hospital Tunku Azizah, over a 10-year period, we have diligently collected data on patients at whom we have treated. We saw about 1,830, and that gives us about 183 cases of children with cancer managed by our center in a year. And that is about 25% of the total number of children with cancer diagnosed and also managed in the whole country. And hence, we are the largest treatment center for children with cancer in this country. So let's look at the progress. I will just sum up and tell you that we have, and I will convince you that we have managed to show that we have improved survival outcome of children with cancer in the country. Okay, there are some problems with the slides, so some of the annotations have run away from where it is supposed to be. But let's start off with leukemia first, and that is about 47% of our what you call cancer burden. And of the leukemias, acute lymphoblastic leukemia makes up the largest chunk, followed by acute myeloid leukemia and the other cancers. So let's start off with acute lymphoblastic leukemia, and I take you to Sarawak. This is a study that was a review that was looked at by Dr. Betty Ho and also Dr. Ong Git Bee over a very long period from 1997 to 2010, managing about 174 patients using two different chemotherapy regimes, the UKALL regime prior to that, and the more recent BFM regime, and they have showed that they have managed to improve the survival outcome from about 65% to 81% for event-free survival, and from 81% to 88% for overall survival. Unfortunately, that is not the case for acute myeloid leukemia, the second most common acute leukemia in Malaysia. These are our experience managing children with acute myeloid leukemia using the UKBML12 protocol over a very long period of time from 2000 to 2011, 154 patients. Although we managed to show that we have improved survival from about 30% to 68% initially over a very short period of time. And that is due to the reduction in toxic death in these children. However, when we expand this period to a longer period of time, we have shown that the survival outcome actually dropped to 50%, and that is contributed by significant toxic death of 15% in this cohort of patients. Okay, and the death occur, half of them occur early during induction, during the first two courses of chemo, but another half of it occur during the second part of consolidation when they are already in clinical remission. And because of that, we then subsequently adopted the AML17 protocol by reducing the toxicity of the consolidation therapy by using high-depth chemotherapy. But actually, there is also increasing the dose in the induction chemotherapy of daunorubicin by about 20%. By doing so, unfortunately, we did not achieve good outcome. In fact, our outcome dropped from 50% to 41%. And that is because of increasing toxic death during the early period, although we managed to reduce toxic death in CR. Let's look back at Borneo again and look at my friends in Borneo, Dr. Betty Ho and Dr. Ong Git Bee. A very long period of time, 122 patients, two different treatment protocols, the UKML12 protocol during the first period, and then the AML15 protocol during the second period. There's some differences in the treatment, but they have managed to show that they have managed to reduce the number of patients who are deemed too sick for chemotherapy. That means at presentation, they are just too sick and they are just validated. And of course, all these patients died, from 14 to just one patient during this period of time. And with that, we managed to improve the survival outcome from about 34% to 56%, although the toxic death rate is still extremely high at 15%. We, at the same time, because of the treatment that we have used and the toxicity that we have given to the patients and killing many of these patients off, we then changed our treatment armamentarium from the UK protocol to a German BFM protocol called the BML BFM 2004. And this is still very early information, but it seems to be encouraging with about 58% of overall survival and reduction in early toxic death to down to 8%. It will take a few more years before we see that whether this is maintained or not. Fortunately, other than this very sad story, most of the other children with cancers are very well managed. As you can see from here, acute promyelocytic leukemia, our long-term survival is 92% from this period, compared to our predecessor before 2010, our long-term survival is only 21%. Likewise, for myeloid, Down syndrome with myeloid leukemia, our long-term survival is 94% currently, as compared to our predecessor, the DAT protocol, whereby the long-term survival is only 30%. We have also made improvements in care for children with lymphoma, and this is mature B-cell lymphoma. So for mature B-cell lymphomas who are stratified under Group B, and this is mostly stage 3 patients, by the addition of rituximab, we have managed to improve survival from 60% to about 100% today. In fact, I do not have anybody who relapsed after treatment with this kind of regime. For the Group C patients, and these are mostly stage 4 mature B-cell lymphomas, in fact, improve survival by reducing the number of triple intrathecals, meaning that we give less chemotherapy, because we found that actually many of these patients died during early treatment. And by reducing the intrathecal therapy, we managed to improve survival outcome from 33% to the current about 90%. Likewise, for Hodgkin's lymphoma, our predecessor regime using the US CCG 5942 protocol, the 3 years event-free survival is 74%. Subsequently, we changed our treatment protocol using the European Euronet PHL-C1 chemotherapy regime, and we have achieved great success in using this new regime. We have achieved what we call a good survival for testicular germ cell tumor as shown here, and ovarian germ cell tumor as shown here. And although despite that, we still do have patients who relapse for germ cell tumors, extracranial germ cell tumors, and we showed here that with the ICE chemotherapy, which is our predecessor regime, survival is only 33%, but with Cabo-Tip, which is our current relapse protocol, we managed to salvage a sizable number of patients. Let's look at renal tumors. Okay, this should read Wilms tumor, and then you have got other tumors here, CCSK being the commonest. So we look at our 10-year survival outcome for Wilms tumor, 91% survival. And when we break it down to the different stages, stage 3, 5-year overall survival of 88%, stage 4, about 80%. Likewise, for patients with non-Wilms renal tumors, in general, our overall survival is about close to 90%. One of the most difficult cancer to treat, solid tumors to treat, is high-risk neuroblastoma, and these are all mainly stage 4 neuroblastomas. And if you look, prior to 2014, all our patients with stage 4 neuroblastoma died. They basically died because we have got no good treatment for them. From 2014 onwards, we started to give them very toxic treatment with high-dose chemotherapy. And for those patients who receive high-dose chemotherapy, the 3-year overall survival is 34%, compared to those who did not receive high-dose chemotherapy. But this is still extremely dismal. Subsequently, from 2018 onwards, we added on other form of treatment, and that is in the form of vidotaximab beta-immunotherapy, this extremely expensive treatment. And we managed to show that we have improved the survival from 34% at 3 years to about 57% at 3 years. And this is for all patients, compared to this where we have not accounted for those patients who did not receive high-dose chemotherapy. And the survival improvement is mainly due to the addition of dinutuximab beta on top of the busulfan and melphalan high-dose chemotherapy that we were giving the patient from 2014. Let's move on to a different cancer now. Move on to children, not just children, but mostly adolescents. So during sarcoma, a bone tumor, the second commonest or most common bone tumor amongst adolescents. Our predecessor protocol, ACES 92, and then we move on to the US COG AWS031, and we showed that survival outcome improved from 60% to 86%. And when we remove the metastatic patients away from this analysis, this improvement is even more remarkable. Unfortunately, we do have patients who refuse treatment, and unfortunately also for those patients who have metastatic disease, there's no curable treatment available, and 30%, and the number of about 30% of these patients make up this cohort of patients that we still do not have a good answer on how we can cure them. As for osteosarcoma, the commonest bone tumor in children, we have not made much progress. Survival is remaining at about 50%. And we also have got patients who refuse surgery and refuse treatment, and that is about 20% of the patient cohort. The survival outcome of 50% is low like this because of the fact that we have got 50% of our patients presenting with stage 4 disease compared to developed country where only about 25% of their patients have got stage 4 disease. So we have got late presentations, besides the fact that we have got patients who refuse treatment. Of course, treatment outcome survival is not good enough. We want to have good quality of life with treatment. And we have looked at patients with bilateral retinoblastoma, with advanced bilateral retinoblastoma. So retinoblastoma is a cancer that affects the eyes. It can affect both the eyes. And these are advanced bilateral retinoblastoma. If you have got unilateral retinoblastoma advanced at this juncture, we will usually enucleate the eye. Enucleate means we remove the eyeball, and hence once you remove the eyeball, the patient will have no vision. So in the predecessor treatment, we were treating them with just Joe plus minus our second line chemotherapy, which is VADC. And the 4-year enucleation-free survival is only 12%, as compared to the St. Jude protocol, which we have subsequently adopted. We managed to improve the enucleation-free survival to 44%, and we managed to reduce the number of patients with no vision from 88%, and this is like no vision, totally no vision, because both the eyes are enucleated, down to about 38%. And not just that, we managed to improve good vision from about 12% to about 50% of patients survive with good vision. Let's move on now to brain tumors. So this is intracranial malignant germ cell tumors. So this is our survival outcome with these patients. Then medulloblastoma, this is the commonest malignant brain tumor in children. Our overall survival outcome is about 64%. Of course, there's a difference between those who are deemed standard risk compared to those who are high risk. And those who are less than 3 years old actually did quite poorly in the past. We have now changed the treatment regime, but I've yet to get the time to look at how we have fared, because the time is just too short for us to look at the survival outcome. We need to wait for maybe a year or 2 years, and hopefully the data is a bit more mature and I can share with you in the future. But unfortunately, many of these patients with medulloblastoma, even though they are cured of their cancer, they are not without problems. And this is the long-term morbidity suffered by 30 patients, and only 2 of these 30 patients do not have significant neurological deficits or endocrine complications, compared to the rest of them have some amount of neurological residual deficits or endocrine complications because of the cancer as well as the treatment that we have to give the patients. So let's look at some other challenges. So from this incidence of childhood cancer, as reported by the National Cancer Registry, over the 5-year difference in period, there is a sizable increase in number of patients, about 204 patients. And this is also reflected by the data that we collect over the last many years, and we see that there's significant rise in the number of patients for brain tumors retinoblastoma, liver tumors, as well as bone tumors that we need to treat. I don't expect you to read or look at this. This is the, these are the treatment centers available in the whole country. This has been recently been updated, but suffice to say that most of the treatment centers are in the Klang Valley. In the country today, we have got 7 treatment centers in the Ministry of Health hospitals, 3 university hospitals and 3 private hospitals, with about 29 plus minus 5, plus minus 5, because the other 5 doctors are not full-time doctors. Okay, this is as compared to 2015, that's about 10 years ago. The total number of patients, 26. In terms of centers, we have only 1 increased private center since the last 10 years. And although we managed to improve the number of treating pediatric oncologists from 26 to 34, and there's about 30% increase. So what are the other challenges that we see? Some of the other challenges that we face are the cost of treatment, because treatment in the Ministry of Health hospital, the cost of treatment in the Ministry of Health hospital is not the same as treatment in the Ministry of Education hospitals. So unfortunately, children who come from poor socioeconomic background, they will refuse to go to the Ministry of Education hospital for that reasons. School children gets free treatment. I should emphasize is government school children gets free treatment. Non-school children or children who are going to private schools, and that includes religious schools, they will not get free treatment. So hence, the cost of treatment is very different. The treatment coverage areas, as I've shown you earlier, there's a difference between East Coast as well as West Coast, Peninsular Malaysia, and of course there's also a difference between Peninsular as well as Borneo. Current hot topic that we are at discussion at the ministry level is what should we do with teenagers? Teenagers fall between the gaps, because should teenagers be managed by the pediatric service or by the adult service? Our current practice by the Ministry of Health is once you've got IC more than 12 years old, you will automatically go to the adult service. We know that the adult service is overburdened by the care of not just cancer patients, but by everything in general. And hence, there's a lot of delay in the treatment for adolescents who end up in the adult services. And in the adult services, they are not, in pediatric as well, but not everybody is geared towards thinking or differential diagnosis of cancer. Okay, so the question is, can we cope? So 15 to 19 years old, about 250 patients a year. But let's look at who we have been treating, right? So this is data from our center, and if you look at the top bar, and that's the green one, we have only treated a small minority of adolescents, and these are patients above the age of 12 years old. We still have challenges for patients who refuse treatment or abandon treatment, and roughly that's about 5% of patients. Many of these families try alternative treatment until their disease progress, and that causes their disease to be upstage and hence reduce curative rate. Not only that, even if they are able to cure them, many of them will have permanent sequelae, especially if they have got cancer arising from the brain, arising from the nerves or important organs, whereby these organs need to be sacrificed for those reasons. We have got poor social support for patients who refuse treatment, and this includes the welfare department or medical social worker are not geared towards this, and of course children are not eligible for worker B40. Although there's legislation like the Child Act, but fostering services are actually not in existence in this country, and hence even though we can use the Child Act, because of lack of fostering services, we are not able to take much actions. We have shown that we have managed to reduce the truth death rate from about 28% from the beginning of the last decade to now close to about 25%, but unfortunately with the COVID-19 pandemic, our trajectory gets skewed a bit. So in summary, I've shown, or I hope that I've convinced you that we have improved survival rates for children with cancer over the years. We hope that this is mostly data from my center. We hope that other treatment centers are able to replicate this success story. We have got lots of work to do to catch up with the cure trajectory after the COVID pandemic. Treatment refusal and abandonment is still a problem. Civil society needs to create awareness of treatment success. We need to provide holistic care for both the patients and as well as the family. We need to provide good quality of life to these patients, provide love, care, laughter and hope. And we need to address the cause of cure, not just from the money point of view, but also emotion, psychology and rehabilitation. Childhood cancer is not preventable, not like adult cancers, but treatment abandonment and refusal. I've got lots of people to thank, and these are some of these many societies that have supported us over